Imagine this. You're sick. And I don't mean, call out of work sick. I mean, you are really, truly down to the count.
Right.
A high fever, the kind that gives you the shivers under 3 blankets 1 minute and then you're sweating through the sheets the next. You're in the hospital, the doctors look worried, and boom, you're on antibiotics. The strong
The
ones.
heavy artillery.
Exactly. And you're just lying there waiting for one thing. You, your family, the nurses, everyone is just waiting for that fever to break.
It's the universal sign of relief, isn't it? We are conditioned from childhood to think that the moment the temperature drops, the battle is won.
The ghost has left the machine.
Yes. But that's where it gets interesting.
Right. Because from a clinical perspective, that moment, it isn't just relief. It's actually a high-stakes decision point. It's a fork in the road.
A huge one. And that's what we're digging into today. We're talking about two concepts that sound a bit technical, but are, well, they're fascinating. Defervescence and antibiotic de-escalation.
Defervescence. It sounds like something that happens to flat champagne.
It does have a ring to it, but in medicine, it just means the resolution of fever. A fancy word for cooling down. And look, it is a key marker that the therapy is working, but, and this is the core of our deep dive today, relying on it alone.
Uh-oh.
That is a trap.
A trap. Okay, so let's unpack that. We've got a huge stack of sources here. Clinical guidelines from the Infectious Diseases Society of America, the Society of Critical Care Medicine.
Some really heavy-hitting meta-analyses, too.
So what's the mission here? What question are we trying to answer?
The mission is to figure out how doctors know when to stop the heavy artillery, the broad-spectrum antibiotics, without risking a relapse. Because the sources are clear. The old school method of just blast it until it's gone is actually causing more harm than good.
Okay, so let's start with the baseline. If I have a serious infection like pneumonia or sepsis, and I start taking the right meds, what does normal look like? Is there a schedule?
There is. If you look at the guidelines, there's a pretty consistent timeline for most of these common serious infections, sepsis, pneumonia, bacteremia.
Bacteria in the blood.
Right. Defervescence typically occurs within 48 to 72 hours of starting the appropriate antibiotics.
48 to 72 hours, so 2 to 3 days.
That's what we call the magic window. The IDSA and the Society of Critical Care Medicine, they actually recommend a formal reassessment right at that 48 to 72 hour mark.
So it's not just paperwork. It's biological.
It's completely biological. It's the time it takes to knock down the bacterial load enough for the body's inflammatory signals to start quieting down.
So if I'm in the hospital with community-acquired pneumonia, the clock is ticking the moment that IV drip starts.
Correct. For that specific condition, the data shows clinical improvement, including fever resolution, is expected within 72 hours for most cases. If you hit that mark, it's decision time.
And what's the decision? Is it just keep going or stop?
Oh, it's much more nuanced. The goal at this stage is to determine if the patient still needs broad-spectrum therapy.
Okay, define broad spectrum for us. I hear that term all the time.
Think of it as a carpet bomb. When a patient comes in crashing, we don't know who the enemy is yet. Is it staph, E. coli, something else? So we use a drug or a combo of drugs that kills everything.
Shock and awe.
Exactly. But at 72 hours, the goal is to switch to something targeted, a sniper shot. We call this de-escalation.
Okay, I have to play devil's advocate. If the carpet bomb is working and the patient's feeling better, why change it? Why not just keep the strong stuff going to be safe?
That is the most intuitive reaction. And it feels safer, I get it. But the sources we have today show why that intuition is actually dangerous. The guidelines call it stewardship principles, and they outline 3 massive risks.
What are we risking?
First, antimicrobial resistance. You are quite literally breeding superbugs. By exposing all bacteria in your body to these powerful drugs, you are selecting for the nastiest mutants that won't respond to anything next time.
Right, creating monsters. It's bad for society, sure.
It's bad for the patient, too. They can get secondary infections like C. diff. But let's talk about the other risks. There's cost, of course, but more importantly, adverse drug events. Specifically, acute kidney injury.
Acute kidney injury. So trying to blast the infection for too long could actually shut down your kidneys.
It significantly increases the risk. A lot of these broad-spectrum agents, like vancomycin, can be pretty toxic to the kidneys.
That puts a whole new spin on just to be safe. You think you're playing it safe, but you're actually poisoning the filtration system.
It really does. And the data here is solid. Large multi-center studies show that de-escalation switching to that targeted therapy by day 4 is associated with lower risks of acute kidney injury, lower risks of ICU admission, and even lower in-hospital mortality.
Wait, let me get this straight. Stepping down the treatment Making it less intense actually leads to better survival rates.
Similar or improved outcomes, yes. It's totally counterintuitive, but by day 4, if you're still using the carpet bomb when a sniper rifle would do, you aren't fighting the infection any better, you're just adding toxicity.
Wow. It's like once the fire's under control, you don't need the fire hose anymore. You just need a bucket. If you keep using the hose, you're just going to flood the house.
That's a perfect analogy. You're causing water damage to put out a fire that's already smoldering.
So how do doctors know when it's safe to switch? The fever breaking? Is that the green light? Fever's gone, switch to the meds?
No. And this is so crucial. The sources are very, very clear on this. Fever resolution alone is not enough.
Why not?
Because fever can be masked. Maybe you took Tylenol. Maybe your immune system is just taking a temporary break. You need a full checklist. To de-escalate safely, you need 3 pillars. First, clinical stability.
Which means?
It means their blood pressure is holding steady without meds to prop it up. Heart rate is normalizing. Oxygen levels are good. Basically, their vital organs aren't screaming for help anymore.
Okay, check 1. Body is stable. What's number 2?
Microbiologic data. The lab. You need to know your enemy. Ideally, we have cultures back that say, aha, this is streptococcus, or, just as important, negative cultures telling us what it isn't.
Right. If you know the bug, you know what kills it. No more guesswork.
Precisely. And a huge part of this is screening for the really bad guys. The guidelines mention negative MRSA nasal swabs as a key indicator.
How does a nose swab help a lung infection?
Great question. So MRSA is a resistant staph that often lives in the nose. If we swab your nose and it's negative for MRSA, the odds you have MRSA pneumonia are extremely low. That one test gives us the confidence to stop the heavy anti-MRSA drugs.
Which saves your kidneys.
Exactly. And the third thing is just making sure you didn't find a superbug that needs the heavy stuff anyway. But if those 3 things align stability, good lab data, no superbugs, you de-escalate.
And I'm seeing the role of technology here with rapid diagnostic tests.
Yes, speed is everything. We used to wait days for a petri dish. Now we have molecular tests that can ID bacterial DNA in hours. It just lets us de-escalate so much faster.
So I want to clarify something. You're saying that if you have clinical stability and the right lab data, you can stop the heavy meds, even if the patient is still kind of sick.
Let's push that even further. Let's talk about a really nuanced case from the sources. Febrile neutropenia.
Febrile neutropenia. That sounds very serious.
It is. These are usually cancer patients on chemo. The chemo wipes out their neutrophils, their white blood cells. Their immune system is at 0.
So they were walking a tightrope without a net.
Exactly. And for decades, the rule was, if a neutropenic patient gets a fever, you put them on broad-spectrum antibiotics, and you do not stop until their white blood count recovers.
Makes sense. If they have no defense, don't take away their armor.
But recent meta-analyses have they've blown that up. They show you can actually de-escalate antibiotics before their neutrophil count recovers.
Whoa. So their immune system is still down, but you're pulling back the big guns.
If, and this is a big if, they are clinically stable and the criteria are met. The studies show it reduces mortality and side effects without increasing the risk of relapse. It's a huge shift.
That is bold. It really shows how much damage those broad-spectrum drugs can do.
It proves that the toxicity of the cure can become a greater threat than the lingering risk of the disease, provided the patient is stable.
Okay, let's flip the script. Let's talk about the fever trap.
Ah, yes, the fever trap. This is where the thermometer starts to lie to you.
So I'm on the meds. It's been 72 hours. The magic window is closing. But I still have a fever. Time to panic. Do we need stronger drugs?
This is the instinct. The doctor thinks, it's not working. Hit it harder. But the consensus is clear. Persistent fever does not always mean treatment failure.
Really? Because if I'm still hot, I'm assuming the bacteria are still winning.
Not necessarily. Switching therapy just because of a fever is often unwarranted. Let's look at pyelonephritis, a kidney infection.
Okay.
The source material cites a specific stat. In uncomplicated cases, up to 29% of patients still have a fever after 72 hours.
Almost a third of them.
Yes. And it doesn't mean they need new antibiotics. The drugs might be working perfectly, but the body's inflammatory response is just taking its sweet time to cool down.
It's like a car engine. You turn the key off, but the hood stays hot for a while.
That's a perfect way to put it. The infection is the engine. The fever is the heat. Just because there's heat doesn't mean the engine is still revving.
So that knee-jerk reaction to escalate, to throw more drugs at it.
It just promotes resistance and adds side effects for no benefit. But there's a flip side to the fever trap, too.
Which is?
Fever resolution isn't a get-out-of-jail-free card either. You can be a febrile, no fever, but still have a raging infection.
So I could be cool to the touch, but still be in big trouble.
It's possible. In elderly patients, their immune system might be too tired to even mount a fever. Or, in sepsis, you can go from a high fever to being too cold hypothermia, which is a really bad sign.
That's terrifying.
Which is why the guidelines keep coming back to clinical stability. You treat the patient, not the thermometer.
Don't treat the thermometer. We should put that on a t-shirt. So why does this vary so much? Why do some people cool down in a day and others take a week?
Well, there are a few key variables: the infection site, the virulence of the bug, the patient's own immune system. But there's one really big one: source control.
Source control. Sounds like a spy movie.
It just means physically removing the infection. If you have an abscess, a pocket of pus, you have to drain it. If you have an infected catheter, you have to pull it out.
So if you don't drain the abscess, the fever won't break no matter what.
Exactly. Antibiotics have a hard time getting into a walled-off abscess. You can pump a patient full of drugs, but if you don't drain the fluid, the bacteria will just sit there and persist.
So the first question shouldn't be, what drug do I add? It should be, is there something I need to drain?
That's it. And the timeline varies by infection, too.
Let's run through a few of those. What about bacteremia?
Bacteria in the blood. It's a race against time. Every hour of delay matters. But once you're on the right track, most patients defervesce in 2 to 7 days.
That's a bit of a range.
It is. A staph aureus infection can take longer to clear than an E. coli one.
What about endocarditis? Infection of the heart valves, right?
Yes, and that's a tough one. Fever usually clears in 3 to 7 days. But, and here's a massive red flag, if it stays longer, it could mean embolic phenomena.
Embolic phenomena. That sounds bad.
It is. The bacteria form clumps on the heart valves. If the fever persists, it might mean pieces are breaking off, traveling through the bloodstream to the lungs, the brain.
Causing strokes or abscesses somewhere else.
Exactly. So in that case, persistent fever is a warning sign, but it's a sign of a physical complication, not necessarily a sign you just need to switch antibiotics blindly.
It really is detective work.
It is. You start broad, then at that 48, 72-hour mark, you stop, you look at the evidence, and then you de-escalate.
It seems like the whole field is moving away from that shock and awe approach toward this precision sniper approach.
That's exactly the trend. We're realizing that biology is messy, and our tools, our antibiotics, are a finite resource. If we overuse them, we lose them.
So for the listener, the big takeaway is that magic window, 48 to 72 hours. That's the turning point.
It is. That's the moment the strategy should shift. And it's important to understand that improving doesn't always mean perfect. You can be getting better and still have a low-grade fever as long as your organs are stable.
And just because the fever is gone doesn't mean you're out of the woods if your blood pressure is tanking.
Exactly. You have to look at the whole picture.
And this de-escalation strategy, it isn't about being cheap. I think that's the fear.
It's absolutely not about money. It's about safety. We used to think safety meant more drugs. Now we know safety often means the right drug for the shortest necessary time.
Realizing that stepping down is actually a step forward.
Perfectly put.
So we live in a world where we want instant results. We take a pill, we want the symptom gone. But these guidelines are really telling us to be patient with the biology.
They are. They are asking us to trust the clinical data over our own anxiety. When a doctor says, we're going to stop the heavy antibiotic and switch to this lighter one, that isn't negligence. That is high-level evidence-based medicine. They're protecting your kidneys and preventing the next superbug.
It's a brave new world of antibiotic management.
It is, and it requires us to tolerate a little bit of ambiguity.
Which brings us to our final thought. We think of recovery as this straight line. You're sick, then less sick, then better. The symptoms just check off a list.
But the source material suggests biological recovery is messy. It's a jagged line. You can be healing while you're still feverish. You can be failing while you're cool to the touch.
In an era of rising antibiotic resistance, our ability to tolerate that ambiguity, to trust the clinical data over the simple number on a thermometer, that might be the very thing that saves us.
It's a total shift in mindset. We have to learn to read the body, not just the device.
And on that note, we're going to let you digest all of that. Next time you see a thermometer, remember, it's just one data point in a very complex story. Thanks for diving in with us.
Stay curious, everyone.